Hi guys, welcome to the Finals Crash Course series. Today we'll be covering palliative care and end-of-life care with Dr. Oliver Maynard. So in the top right corner is the QR code for our Instagram page. So if you're not following already, please scan and follow. And in the bottom left corner is our email. If you have any questions, please do email us. If you want to go to the next slide. So we have loads of SBAs in the session. So if you want to join in and just try and answer, that's the QR code for the polls. I'll also post it in the chat. But yeah, I'll hand over to Ollie now.
Thanks, Atch. Hi everyone, my name is Ollie. I'm a Foundation Year 2 doctor working in West London, and I'm going to do a bit of a talk today on palliative care, aimed at sort of end of med school finals level. The bulk of the talk is going to be some single best answer questions. There should be 15 of them, where we'll give you a vignette and give you a few seconds to think of the answer, and then I'll try and explain the answer. They're boosting polls as we go along, so if you want to be join in and be interactive, and then at the end I can give you some top tips on the prescribing and safety exam, which some of you might be taking quite soon or may have already taken. Yeah, and if you have any questions at the end, you can always email us and we'll try our best to answer. So just to let you know, this is for educational purposes only. So all this information was correct when I gathered it and made the slides, which admittedly was about a year ago now. And yeah, this is just for educational purposes, so this doesn't count as medical advice, but I hope you find it useful towards your medicine exams.
So these are the things that I'll try and be covering in the next hour. So just a quick overview on the principles of palliative medicine, which hopefully you guys should be pretty familiar with anyway. And then the bulk of the presentation, I'll go through 15 single best answer questions, give you time to answer them, and then try and give an explanation of the answer. So I've come up with these questions myself, obviously using lots of different resources. So it's just sort of the answers that I think are correct. I've tried to corroborate that with lots of evidence. But let me know at the end if you feel like any of them kind of need some attention. And then right at the very end, some of you might have already done your PSA already, but for the ones who haven't, I've got some top tips for the PSA, just because palliative medicine has a lot of prescribing in it and a lot of it's relevant to the PSA. Just before we start, I'll let you know that I've got COVID, so I apologise if at any point I need to have a drink or cough or anything, so I apologise in advance of that. And I hope I've set the questions at the right sort of level. I've tried to think back about what I needed for finals and what I sort of needed to know. So I hope they're not too easy and I hope they're not too hard. But that being said, so palliative care is always good to start off with a definition. And the World Health Organization describes it in quite a long way, but I'll just quickly go through it. So an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering, the early identification, treatment and pain and other problems, physical, psychosocial and spiritual. So I think there's sort of three main things to pick out from there. The first one being improves quality of life. So obviously palliative medicine, there's quite a change from curative treatment to treatment of symptoms, and often that improves the quality of life rather than the quantity. The second point is patients and their families. So there's a really big stress in palliative care about treating the patient and their families as a whole, because often they'll be going through the same sort of things together, and often to treat the patient you also have to treat their family. And then the final one is the idea of the physical, psychosocial and spiritual aspect. So it's a very holistic area of medicine. We have to think about the patient as a whole, and you're not just focusing on physical disease. And you find that in practice that a lot of the time you'll be spent talking to the next of kin, talking about their religion, what sort of chaplain they need at the end of life and stuff like that. So I thought it was important to define it that palliative care does not equal terminal care. So often it's used clinically to mean the patient is in their very last few hours or days of life. However, patients under the palliative care team can be under them for days, months, weeks, or even into years. It doesn't necessarily mean they're actively dying. So palliative care includes terminal care when they're actively dying or deteriorating. But it's also a branch of medicine where they're treated way before that, and also treating family members after the patient has passed away. So the main principles are focusing on quality of life, like I spoke about previously, that whole person holistic approach. It encompasses what's important to the patient, which is quite unique for a specialty of medicine, whereby it's normally the healthcare professional which sort of dictates what's the most important thing to treat, whereas it's very patient-led, so you have to have a really good patient-doctor relationship, and also obviously respect their autonomy and choice, because there'll be a lot of the decisions that will be made were down to the patient's choice. And obviously it's a place where you have to have expert communication, have some very challenging conversations, but also some very gratifying conversations with patients. So there are 4 main pillars of palliative prescribing. Often this is called anticipatory medications, because they're prescribed prior to when the patient actually needs them, with the idea that they may need them at some point. And normally a medication is prescribed for one of the 4 following. So one for pain, one for respiratory secretions, one for nausea and vomiting, and one for agitation. So these are the major 4 pillars of palliative prescribing, but as we'll soon find out in the rest of the talk, there are lots of other symptoms that palliative care physicians have to treat. It's not solely these 4, but these are the main 4 problems that they come across. So we'll move on to some of the questions. That was just a brief overview of palliative care. So I guess I will open the poll and speak them aloud and give you some time to answer, and then go through the answer afterwards. So let's open the poll for the first question. Hopefully that should have worked.
Yep.
So you're working on a general medical ward and looking after a 79-year-old female with advanced small cell lung cancer with brain and spinal column metastases. She's a background of depression, type 2 diabetes, ischemic heart disease, and suffering from episodes of nausea and vomiting. Which is the most appropriate treatment to start regularly? Haloperidol 1 mg, cyclizine 50 mg TDS, levopromazine 6 mg OD, metoclopramide 10 mg TDS, or domperidone 10 mg TDS. I'll kind of wait until you guys stop voting or stop changing your votes, and when it's sort of settled, then I'll close the poll and give you the answer. Okay, so it seems like we're sort of set on the positions now, so I'll stop that there. It seems like the majority went for D-metoclopramide, and if I show the correct result, so B, cyclizine, and I'll go on to describe why. First of all, I'll just go through sort of vomiting and nausea and vomiting in general. So the vomiting center, or the emesis center, is found in the medulla of the brain, and it gets inputs from multiple different sources. One of the main ones being the chemoreceptor trigger zone, which can also be found in the medulla, which gains sort of stimulation from multiple different sources, electrolyte abnormalities, and certain medications. Other inputs to the vomiting center include peripheral pathways. So this might be from the gastrointestinal system through the vagus nerve, also through the vestibular system, through the vestibular nuclei, which then eventually feeds into the vomiting center. And then you also have those higher cognitive processes in the cerebral cortex, stuff like anxiety, which can all lead into the vomiting center. And then if the threshold is met, it will cause a vomiting response. Lots of different transmitters are used to stimulate the vomiting center, which is why there's lots of different types of antiemetics and lots of different mechanisms of actions. But if the threshold is met for a patient to vomit, they'll go through these physiological changes in turn. So there has to be increase in the pyloric tone to stop anterograde flow of stomach contents, and reduction in the tone of the lower esophageal sphincter. The glottis and vocal cords have to close to try and stop aspiration into the lungs, but we obviously know this isn't always perfect. The soft palate rises to try and stop reflux into the nasopharynx, but again, we know this isn't always perfect. And then eventually the abdominal wall and the diaphragm contract to expel the contents from the stomach up and out of the mouth. So these are the main classifications of antiemetics. As you can see, most of them target a specific neurotransmitter. So anticholinergics such as cyclizine is one of the examples, affects the oh, sorry, it's not anticholinergic, my mistake. Like hyoscine affects ACTH receptors in the vestibular nuclei. Antihistamines, that's the cyclizine, affects H1 receptors, which thereby affect, again, acetylcholine receptors in the vestibular nuclei. Dopaminergic, such as haloperidol, levopromazine, quite a few in this class, prochlorperazine, affects dopamine directly in the chemoreceptor trigger zone. Neurokinin receptor antagonists, which aren't very common, they're not really used much in clinical scenarios, but they affect substance P. Prokinetics, which is like metoclopramide, mostly affect the gut and increase gut motility, increase gut motility, decrease gut transit time. Serotonin blockers like ondansetron have both action in the GI tract, because most of our serotonin is actually in our GI tract, but also on the central nervous system. And then tetrahydrocannabinoids, THC, is quite a niche antiemetic, but they're being used more commonly now in sort of oils and stuff. So each different antiemetic will be used for a different indication. So as we can see on the left-hand side, it entirely depends on the cause of the nausea and vomiting. In this instance, the patient had metastatic cancer with cranial metastases. So as we can see, cranial metastases are most likely going to be their cause of nausea and vomiting. So cyclizine would be our first line choice of antiemetic in this circumstance. Dexamethasone is often commonly used as well as an antiemetic, but also actually to reduce the swelling surrounding the metastases. But other indications for nausea and vomiting, such as like delayed gastric emptying, the first line choice would be metoclopramide to try and increase that. So to try and identify which antiemetic you need to use, you need to first try and identify what would be the reason for them to being sick. And often these are overlapping. Often you can have drugs and opioid in palliative care, as well as some anxiety and pain. But in this circumstance, I believe that cyclizine would be the first line choice. So just in general, in terms of treating nausea and vomiting, you have those pharmaceuticals that we've talked about, but there's also lots of other things which can help nausea and vomiting. It's a very multifaceted symptom. So you can have reflux, which can cause nausea, which you can treat with PPIs. People are very dehydrated, can get very nauseous. People in a lot of pain. So once you actually control their pain, their nausea goes down as well. People can also have anxiety attacks or be very anxious or stressed. And actually controlling that would actually control the nausea better than any antiemetic. And then there's some more traditional treatments such as ginger and peppermint, which help settle the stomach, and other things like aromatherapy, massage, especially temporal massage and acupuncture, all which have shown benefit in nausea and vomiting. So remember, there is lots of therapies outside just simply the standard medication. Brill, so we move on to question 2. So I'll open the poll for question 2. So you're working in a hospice and looking after a 56-year-old male with glioblastoma. He's at the hospice for terminal care. His GCS is 12 out of 15. He is mostly confused with moments of lucidity. In his advanced care plan, he states he wishes to remain alert for as long as possible. On examination, you note he has audible, noisy breathing and crackles on auscultation. Which is the least appropriate drug to start in this circumstance? I won't go through and read them all. So it seems like most people have voted there. So I'll stop the poll and show the correct answer. So I put down there hyoscine hydrobromide, 400 micrograms subcut, and I'll go on to explain why. So the mainstay of treating breathlessness and respiratory secretions, which is what this patient is suffering from, is anticholinergic medication. So I'll quickly just remind us on the mechanism of action of anticholinergics. So these three at the top are sympathetic nervous systems, and this one at the bottom is parasympathetic. So both the sympathetic nervous system and parasympathetic nervous system uses acetylcholine as the preganglionic neurotransmitter. However, post-ganglionic, the sympathetic nervous system tends to use adrenergic neuroreceptors like noradrenaline and adrenaline, whereas the parasympathetic post-ganglionic neurotransmitter of choice is the acetylcholine again. So anticholinergics actually act on the acetylcholine receptors on postganglionic neurons, so they mostly affect the parasympathetic nervous system and block transmission of that neural impulse. So when I see the word anticholinergic, I think of anti-parasympathetic, or simply the other way around, thinking of that as sympathetic. So obviously, if sympathetic is fight or flight response, then parasympathetic is the rest and digest. So that increases secretions from our salivary glands, which obviously if we block, then that's going to cause drying up of our respiratory secretions. So that's the main mechanism of action. But you also can think of other anticholinergic medications, such as atropine, which increases the heart rate, because obviously it will be that fight or flight response, and causes dilatation of the pupils to try and get as much light in as possible. Tiotropium bromide causes bronchodilation, because obviously in the fight or flight response, we want as much oxygen coming in. And oxybutynin is a medication which stops the contraction of the bladder muscle wall, because obviously if we're being attacked by a lion or whatever in the wild, then we don't want to be urinating. It's not a very safe time to urinate. So yeah, so anticholinergic, think anti-parasympathetic. So the then question goes into which anticholinergic we use. So glycopyrronium, hyoscine butabromide, and hyoscine hydrobromide are the mainstays of treating respiratory secretions in palliative care. All of them can be used. All of them are very applicable, have very good, work very well. However, as you'll see here, that hyoscine hydrobromide, as we've started to reveal the answer, can cause sedation and confusion. So the reason for this, as you'll see in the first bullet point, is that hyoscine hydrobromide of the three is the only one which crosses the blood-brain barrier and actually acts centrally, especially so in elderly people. So this can have positive desirable effects. So it can cause the patient to be more drowsy. Obviously, hyoscine is used as an antiemetic if you kind of use quells, which are the kind of generic over-the-counter anti-sickness tablets. That's hyoscine hydrobromide. However, in certain patients, like the patients we're talking about here, whose desire was to remain as alert for as long as possible, this would be an undesirable side effect of the medication. One that butabromide and glycopyrronium don't actually have because they don't cross the blood-brain barrier. So this is from a patient leaflet on the side effects of hyoscine hydrobromide. And the way that I remember it is the H in hydrobromide is the H for head. So it crosses the blood-brain barrier. And this is a real example of why palliative medicine is very patient-focused, and you have to treat your patient as an individual, because this patient had specifically stated that they wanted to be alert and try not to be as drowsy and not be sedated. However, other patients might find that actually they're having lots of anxiety and they actually might prefer to be a bit sedated. So your choice of anticholinergic will actually come down to the side effect profile. And that's what we find in lots of palliative care drugs, that one is not necessarily better than the other. It's very situation dependent. So in terms of overall management of secretions, I think it's important to note that when you prescribe an anticholinergic, it won't clear any respiratory secretions which are already there. It'll only stop any new secretions being generated. And the first steps are to have non-pharmaceutical treatment. So obviously prevention is better than cure. So trying to make sure that they aren't fluid overloaded, to make sure that the hydration is adequate, but not too much, to make sure they're not secreting too much. Obviously, we can use suction to try and remove some of the secretions which are already there. And patient position, so sitting them up, having their head to the side or in the lateral position to help drainage of respiratory secretions. Obviously, if these 3 things or 4 things fail, we can move on to pharmaceutical treatments. This is actually from the Scottish Palliative Care Guidelines, which puts hyoscine butyl bromide as their first line. In the trust that I work in and the many trusts that I've seen, glycopyrronium is actually the first line choice. So it's different in the UK. However, both of these are probably, you would choose them before hyoscine hydrobromide, unless of course that patient would be adequate for the side effect profile. So next question. Hoping it's all making sense so far and it's I'm being clear. So you are caring for a 69-year-old male with adenocarcinoma of the prostate with bony metastasis in the spinal column. He currently takes 10 milligrams of oxycodone modified release orally twice daily, and he takes 2.5 milligrams immediate release for PRN breakthrough pain. You wish to convert his background analgesia to a fentanyl patch. Which patch is the most appropriate? So a fentanyl 12 patch, a fentanyl 25 patch, a fentanyl 50 patch, fentanyl 75 patch, or a fentanyl 100 patch. It's going to take some time to do the calculation on this one, so I'll leave it a bit. Okay, so we'll go through to the answer. So I went for the fentanyl 12 patch here, and I will go on to explain why. So the calculation for trying to convert analgesia to a patch obviously can be found on the BNF. So he was taking his 10 milligrams twice a daily, so he's taking 20 milligrams of his oxycodone. And we have to convert that into oral morphine to try and make the conversion. So the table on the left, that we can see that 10 milligrams of morphine per oral is equivalent to 6.6 milligrams of oxycodone. So oxycodone is about 1.5 times as strong. So he's having the equivalent of 30 milligrams of morphine sulfate daily. He wasn't using any PRNs at the moment. He had them prescribed, but so his entire opioid intake for the day was 30 milligrams of morphine, which we can see in the conversion table converts to the fentanyl 12 patch. So a 12 patch means that he'll be getting 12 micrograms of fentanyl per hour, and patches usually last for 3 days, so 72 hours. And then obviously they need to be replaced on that 3rd day. So 12 refers to obviously the 12 micrograms, but that's not over the whole 24-hour period. That's every hour for the 24 hours until the patch needs to be changed. So next question. So you're on call on the surgical rota and you're bleeped to see a patient who is day 2 post-op for an open repair of the para-umbilical hernia. He's taking paracetamol 1 gram QDS, tramadol 100 milligrams TDS, Senna 15 milligrams once nightly, Danzatron 8 milligrams TDS, Kermoxiclav 625 milligrams PO TDS, and atorvastatin 20 milligrams once nightly. The nurse states that he has spiked a temperature of 40.2 degrees and has become hypertensive with tachycardia. From the end of the bed, you can see he is sweating heavily. Given the diagnosis, what is the most appropriate initial treatment? To escalate antibiotics to tazocin, to escalate antibiotics to intravenous coamoxiclav, to observe and monitor closely, to give cyproheptadine 12 milligrams, or 15 litres oxygen via non-rebreathe mask. Okay, so it seems like most people in that one have gone for A, to escalate antibiotics to tazocin. So let me show the answer and show you my reasoning. So I've gone for cyproheptadine 12 milligrams, and I'll explain why. So I think this patient might be suffering from serotonin syndrome. So serotonin syndrome is a very rare but clinically important syndrome caused by excessive serotonergic activation. So it can be diagnosed with the triad of cognitive changes, including anything from agitation and confusion all the way to hallucinations and in some cases coma. Autonomic changes, so increases in the heart rate, blood pressure, obviously fever as well. And then neuromuscular changes, so most commonly hyperreflexia and myoclonus or clonus of the limbs. So the reason I thought this patient might be suffering from serotonin syndrome is that he is on 2 serotonergic medications, both ondansetron and tramadol. He's on the maximum dose of both of them and is receiving TDS tramadol and I think TDS ondansetron as well. So both of which can increase the risk of serotonin syndrome. So serotonin syndrome is uncommonly caused by one serotonergic medication, but becomes much more likely if you're having 2 or more serotonergic medications, especially if they're in high dose. So serotonin syndrome is almost always iatrogenic, it's almost always caused by medications. So this particular patient was showing signs of obviously very high fever, tachycardia, and also hypertension. So obviously because he's post-op and he's got a fever, often we immediately think fever and go to infection, which obviously would be in the differential for this patient. But if he's septic, he's more likely to have hypotension. Obviously, it's you'd go to examine the patient and do an A to E, and then you might pick up signs that he has hyperreflexia or clonus, or some of the other symptoms of serotonin syndrome. So I understand why you might think that you need to escalate the antibiotics given the small amount of history that we've given you there. But in this situation, I think you might be suffering from serotonin syndrome. So the management of serotonin syndrome, most cases are mild and resolve on their own if you just take away the serotonergic medication. You give them active cooling, active rehydration. Occasionally they need benzodiazepine for sedation of those cognitive problems and neuromuscular problems. But however, in circumstances with severe serotonin syndrome, which this would be a case of because of the tachycardia, hypertension, and because of the extremely high temperature, we can give cyproheptadine, which is a histamine antagonist, but also non-specific 5-HT, so that's a serotonin receptor antagonist also. So just to caveat that by saying there's not a lot of strong evidence for its use, but it is widely used as the antidote for serotonin syndrome. And obviously, after the initial management, you might want to then give benzodiazepines and, of course, withdraw or change the serotonergic medications. Question 5. You are caring for a 71-year-old female with cancer of unknown primary with liver and lung metastases. She's currently on diamorphine subcut pump, 40 milligrams per 24 hours. The nurses believes she is showing signs of opioid toxicity. Which of the following is not a sign of opioid toxicity? Clonus, snoring, low respiratory rate, dilated pupils, or reduced GCS? Okie dokie. So most people have gone for D, which I agree with, dilated pupils. So there are lots of different signs of opioid toxicity. Early signs including lightheadedness, delirium, hallucinations, hyperalgesia. So that's acutely, painful, lots of pain. Allodonia, so that's sensing pain from things which don't normally cause pain, so sort of light touch to the skin or pillows and such causing pain. Postural hypertension and myoclonus. So this is most often described to the patient as jerking of the limbs, which isn't seizure activity. It's specifically the muscles themselves undergoing clonus. And then obviously there's those late signs, including reduced consciousness level and respiratory depression. So if we just go through them. So clonus, yes, we know that that's a common one in the limbs. Snoring, so that's a sign of reduced GCS. So if someone's not asleep, you should always be aware of snoring because they're not protecting their airway. There's those added sounds. Low respiratory rate, obviously opioids affect the respiratory center in the central nervous system and causes respiratory depression. Most commonly, it's seen with pinpoint pupils. So the opposite of dilated pupils. If you see someone with pinpoint pupils, it might be a sign that they have opioid toxicity, and obviously that late sign of reduced GCS. And most of you will know that the cure for opioid toxicity is obviously withdrawing the opioids and giving naloxone as the antidote. So question 6, you're treating a 65-year-old female in a hospice for terminal care of metastatic breast cancer with a background of angina, gout, and CKD with an eGFR of 7. She's on a subcut pump. What is the best analgesia to start her on? Okay, so it seems like most of you have gone for E, alfentanil, which I believe is the correct answer. So obviously this patient has CKD and has a very low eGFR. They have end-stage renal disease. So our choice of painkiller will be dependent on that. So there's really good guidelines. You can find your own trust might have guidelines themselves. In our particular trust, I think any patient, I think it's over 60, automatically gets oxycodone as opposed to morphine, as it's excreted mostly by the liver, but about 70%, I believe, but 30% renal excretion. Morphine has a much higher renal excretion. And obviously we can follow the guidance down here. And for eGFRs less than 10, we can give alfentanil. So alfentanil is 0% excreted renally. So it's the best medication for patients with very poor renal function. And also it's quite useful when you have it in a continuous subcut infusion. So that's what this thing means here. That's a pump, as it's very low volume and has very little interactions with the other drugs that you put into the pump. So it's actually a very useful medication to use in palliative medicine. So there we go. So it's not renally excreted, and it's the drug of choice in a continuous subcutaneous infusion. However, it has a very, very short half-life. That's why we use it as a continuous infusion. We don't use it as PRNs. Yeah, and you can, if you want some more information about these drugs, you can obviously just follow the links that I've provided there. Question 7. Mrs. Jones takes morphine sulfate 20 milligrams QDS and tramadol 50 milligrams TDS. What dose of Oromorph is most appropriate for breakthrough pain? So I'll caveat this question by saying this is quite a odd regime to be on, sort of 2 different opioids, or well, I suppose tramadol has some opioid activity. So this would be quite odd to see. You'd most likely increase the morphine sulfate dose before starting tramadol. However, I just wrote this because I wanted to make the calculations a bit more tricky and a bit more interesting. So it'd be interesting to see this particular combination of drugs actually on the wards, but just for a theoretical idea, how much Oromorph would they require? 2.5 to 5, 5 to 10, 10 to 15, 15 to 20, or 25 milligrams. So it looks like most people have gone for C, which is the one that I would have gone with as well. So just going through the calculation. So breakthrough pain the analgesia that we give for breakthrough pain should be 1/6 to 1/10 of the daily analgesic requirement. So she's receiving morphine 20 milligrams, and she's taking that 4 times a day, so that's 80 milligrams overall. And tramadol 50 milligrams 3 times a day, so that's 150 milligrams over the 24-hour period. So then we convert morphine, the tramadol to morphine. So we use the conversion table here, which we can find on the BNF. So 10 milligrams of morphine is equivalent to 100 milligrams of tramadol. So it's 10 times as strong. So we divide by 10 to get the equivalent dose of morphine, and then add them together. So she's receiving the equivalent of 95 milligrams of morphine sulfate tablet in the 24-hour period. So we can divide by 10 and divide by 6. So she should be receiving somewhere between 9.5 and 16 milligrams for her PRN doses. Obviously, it's very difficult to prescribe 9.5, so we normally round that to the nearest 5. So sort of 10 to 15 milligrams would be her PRN dose. And if a patient is using sort of more than 3 to 4 of these doses per day, you need to think about increasing their background analgesia. 1 to 2 cases of breakthrough pain a day, you would normally keep things the same, but obviously each patient's individual. Question 8. Mr. Smith is being treated palliatively for end-stage HIV. He has a background of HIV, RA, PSP, and asthma. Which of the following is the most appropriate antiemetic to prescribe as an anticipatory medication? A. Haloperidol, B. Chlorpromazine, C. Ondansetron, D. Metoclopramide, or E. Prochlorperazine? So C on danzatron. And this really comes down to the mechanisms of action of all these different antiemetics. So the patient is suffering from PSP in their background history, which is progressive supranuclear palsy. So this is a Parkinson's plus syndrome caused by tau proteins depositing in the basal ganglia, as well as other places in the brain, leading to neuronal death. And so then a reduction in those dopaminergic pathways and reduction in the level of dopaminergic neurons found specifically in the basal ganglia, which obviously will give you those extrapyramidal symptoms. It's normally quicker onset in terms of at a younger age than traditional idiopathic Parkinson's disease, and it has a much quicker progression, unfortunately. So the particular medications, 4 of them were dopaminergic medications, which block dopamine at the D2 receptors, which is excellent for the antiemetic effect, but unfortunately would have the side effect of potentially increasing the extrapyramidal symptoms that he sees from his Parkinson's plus syndrome. So this is from the Parkinson's website and is not an exhaustive list, but some of the medications to avoid in Parkinson's-like syndromes, including chlorpromazine, haloperidol, metoclopramide, and prochlorperazine. So danzatron in that list was the only one which didn't act on dopamine receptors. So you are caring for an 81-year-old male in the terminal phase of his life due to decompensated liver failure. In his advanced care plan, it states he does not want any intervention that would prolong his suffering. His preferred place of death is in a hospice and does not want to be admitted to hospital. He experiences a catastrophic variceal bleed and hematemesis. What is the most appropriate intervention in this case? So it seems like most of you have gone for either A, B, or C there. And of the 3, I would have gone for midazolam 10 milligrams sublingually. So just a quick discussion on terminal agitation. So obviously agitation is one of the 4 main things you're trying to prescribe for in palliative care. So terminal agitation is the agitation which occurs in the last few days of life. It's very common. Greater than 50% of patients will suffer from terminal agitation. It can have lots of presentations, including sort of anxiety to restlessness to hallucinations to sort of hypoactive delirium, and lots of causes as well. So like I said, there's lots of different signs that you need to keep an eye on. Most of them it's intuitive from just looking at the patient to see if they're suffering from agitation. But there's some which you might not know that they're actually suffering from agitation. So it's important to observe the patient closely, obviously go and see them regularly. And the nurses will also check out for agitation. So when someone is being palliated in the terminal phase of their life, they tend to stop routine observations and start palliative observations, which include checking for signs of agitation, pain, respiratory secretions and such. And it can be caused by a whole host of issues. Obviously, these can be overlapping and be multifactorial at the same time. Things that might be common in palliative care would be, tumours from cancer. Altered body levels obviously is going to be almost guareguaranteed when you're coming to the end of your life and your body organs are shutting down, you're going to have some amount of electrolyte abnormality, as well as organ dysfunction. So there's lots of different causes for agitation. And the mainstay of treatment for agitation is benzodiazepines. So just a quick recap on how they work. So they're a class of drug which act upon GABA receptors in the central nervous system, specifically GABA A receptors. So they bind to the alpha and gamma subunit of the gamma A receptor, causing binding. Sorry, I have to get a sip of water. So activation of GABA receptors causes the inhibition of the firing of the action potential. So they're actually an inhibitory neurotransmitter. And so it sort of dampens down the action within the brain. So just as a quick comparison between the major benzodiazepines we use, so lorazepam is a very common one, which would be described as short-acting. Diazepam is a more common one, which would be described as more intermediate to long-acting, and is more given for chronic anxiety due to its sort of how long it takes to onset and how long it's in the system for, so it can stay in there for 20 to 100 hours. And midazolam is the benzodiazepine which is very commonly used in palliative care, mostly because it is got a very short onset of action, but it's also processed quite quickly. And again, it can be used in subcut pumps and doesn't really have any problems with being mixed with other medications. So midazolam is often the drug of choice. So this is quite a useful table, just comparing them all. So we see midazolam at the bottom here. The action of onset is 0 to 15 minutes when you have it orally. So in this particular patient, which was having a very catastrophic variceal bleed, who doesn't want to go back into hospital, who doesn't want any life prolonging treatment which may cause suffering. So giving him packed red cells, I think, would be inappropriate. Mostly because you're not actually in a hospital setting. He said he doesn't want to be admitted to hospital. So similarly, giving him intravenous fluids is probably not appropriate. So lorazepam was one of the options, but it was IV, so he'd need a cannula. It's uncommon for patients in hospice to have a cannula. Some hospices, they do have them. It's even more uncommon to have patients in the community with a cannula. So an oral preparation may be best. So if he's, and it's dissolved very quickly under the tongue, so even if he's still vomiting, they should hopefully still be able to dissolve and get into the system, and it acts very, very quickly. So midazolam would be the benzodiazepine of choice there. So question 10, which of the following pharmaceuticals is not commonly used in the treatment of intractable hiccups? Is it A, metoclopramide, B, pantoprazole, C, dexamethasone, D, nifedipine, or E, morphine? So quite an uncommon symptom, hiccups, that you have to treat in hospital, but it does happen. And morphine is not commonly used to treat hiccups. So there's lots of different causes of hiccups, including gastric stasis, which is why a metoclopramide might be useful, gastric reflux, which is why a PPI might be useful. Stuff like infections, irritation of the diaphragm, and hepatic disease, and also cerebral causes. So lots of different causes. So like with any symptom, it's important to identify the underlying cause before trying to treat, because obviously it will depend on what treatment we give them. So there's non-pharmacological treatments. So stuff like sipping ice water, swallowing crushed ice, breathing into a paper bag, interrupting normal breathing by holding the breath. So all these things that you might try, yourself at home if you're trying to get rid of hiccups. But often if it can't be treated using non-pharmacological treatments, we have to give one of the ones on the previous slide. However, we don't often give low-dose morphine, but there is some indications for low-dose morphine in palliative care, hiccups not being one of them. But we can have cough or shortness of breath in palliative care. So the 1 milligram is unlikely to have any analgesic effect, but it has been shown that the low doses of morphine still have an effect on the respiratory center in the brain. So if anyone suffering from shortness of breath, which is causing them some distress, you can kind of sort of try and slow their respiratory rate and reduce their distress by giving them a trial of some very low dose morphine. Similar for the cough reflex, that's dampened down by the low morphine as well. So that would be the indication for low dose morphine. Question 11, you're looking after a 75-year-old male being treated for a community-acquired pneumonia with his condition has progressively worsened overnight and the decision was made to switch to a palliative approach. He passed away in the morning. You confirmed his death on the ward. He has a past medical history of ischemic heart disease, hypertension, mesothelioma, type 2 diabetes, and benign prostate hypertrophy. Which of the following will be put as 1A on the patient's death certificate? So A, community-acquired pneumonia, B, type 2 diabetes, C, BPH, D, mesothelioma, or E, hypertension. So all of you going for the right answer there. So community-acquired pneumonia. So I've actually lifted this directly from the Antiemetics website. They have a couple more examples that you can go through and pick which you think is the right answer. So death certificates, 1A is the disease or condition which directly led to their death, which in this case would be the CAP. And then you go down from that, from 1B to 1C, through other diseases that led to the eventual cause of their death. So 1B in this case would be mesothelioma, which most likely led them to be susceptible to the community-acquired pneumonia. And then part 2 is for any condition that may have had an impact in their death, but not necessarily directly caused it. So this doesn't mean that in this section you just list every single one of their past medical histories. So BPH wouldn't have been relevant in this situation, so that doesn't have to get listed. So as we can see here, 1A, community-acquired pneumonia, 1B, mesothelioma, and other contributing factors like ischemic heart disease or type 2 diabetes. So you will most likely have to fill out death certificates as a junior doctor. They can be quite complicated. So there's normally always a bereavement office or a bereavement team in the trust or hospital you're working in, and they're normally really helpful. They are brilliant at going through the patient with you and trying to figure out the death certificate. So feel free to contact them if you struggle. So question 12, what framework can be used for breaking bad news? Is it A, the ICE framework, B, the SOAP, C, HARK, D, CAGE, or E, spikes? So yeah, quite an easy one here. I think most people know it's spikes. Most of us have heard of it before and used it before. So just to cover what the other ones are. So ICE, obviously ideas, concerns and expectations, normally used in sort of history taking. SOAP is a framework which people use for writing in the notes. So if you're being asked to write in notes on the ward or as an F1, you can use the SOAP mnemonic. HARK is used to screen for abuse. CAGE obviously used to screen for alcohol, and then obviously spikes used as a framework for breaking bad news. So just to quickly go through it, so setting is really important, so making sure that you have privacy, that you're not breaking bad news in a bay or you know, where other patients could hear. Trying to first understand what the patient or relatives already understand about the disease or the situation, because there's no point going into the complications of a perforated appendix if they didn't even understand why they were in hospital. An invitation, so sort of understanding where they're at and obviously making sure they're on the same page and asking them if you're happy to share with them the information. And then obviously eventually giving them the information that you'd like to give. But obviously it's about being patient and not obviously dropping that on them straight away. It's about giving them warning shots and eventually working in and you think they will fully understand. Obviously showing empathy throughout. This doesn't have to be done in this particular order. Obviously making sure that you're on the patient's side and understand where they're coming from, and then summarizing and strategizing at the end, trying to come up with a plan. So what's important to understand is that for really bad news, often cancer diagnoses, patients won't hear anything after you say cancer. So it's important to give them phone numbers and places to go and to seek information because they won't take anything in. That's been well documented afterwards. They won't necessarily take anything in. So question 13, which of the following statements regarding DNA CPR decisions, so that's do not attempt cardiopulmonary resuscitation, is false? So which of the following is not true? So A, a DNA CPR form is a legally binding document. B, a patient does not have the right to refuse a DNA CPR decision. C, attempts to communicate the DNA CPR decision to the patient and or next of kin must be made unless doctors think that doing so would cause the patient harm. D, DNA CPR forms can be temporary. Or E, learning disabilities, autism or dementia are not reasons to be put on the DNA CPR form. So which one is not true? Okay, so most of you going for the correct answer there. So A. Oh, don't know why I pressed that anyway. So DNA CPR form is not a legally binding document, whereas all the rest of the statements are true. So a DNA CPR decision is simply a tool to help tell doctors and nurses not to attempt CPR. If a patient wants a legal document to say that they do not want resuscitation, they have to make an advanced decision. And then obviously if you're breaking that advanced decision, then you are actually breaking the law at that point. Whereas the standard DNA CPR forms that the patient does not sign, that is just put in place by whoever the healthcare team to try and stop any inappropriate resuscitation attempts. In regards to the other statements, all of which are true, the decision to resuscitate is a decision made by the medical team and should be in conversation with the patient and the next of kin. However, the patient cannot demand to be resuscitated. So they do not have the right to say, you must try and resuscitate me. That's a decision which is made by the doctor, and no doctor has to give a patient a treatment if they don't think it will work. If it's futile, then it's not something we have to do. However, if you do put a DNA CPR in place, like we said, it should be tried to be communicated with the patient, and it should be documented, obviously, by the most senior doctor in charge of the patient's care that's at work at that time. And they can be temporary, so the DNA CPR decisions, they can be revoked if the patient's situation changes or their decision changes. And often the ones they have in hospitals are temporary, and if they go home, they won't continue with them into the community. So there's a really good website, it's just the NHS website, but it has explanations of all these things, which is where I got all this information from, so it's quite a good resource. Question 14, which of the following is not a typical part of the death confirmation exam? So when you're confirming death, which bit is not typical? So A, auscultating for heart and breath sounds for 2 minutes. B, checking for a central pulse, C, an ECG, D, checking pupillary response, and E, checking the patient's response to painful stimuli. Yep, so all of you got it. So it's the ECG. So it's not commonplace when you're doing a confirmation of death exam. So these are the usual steps. So when I confirm death, I would take the approach as I would with any patient. So I observe the patient from the end of the bed. So that's looking for spontaneous movement or spontaneous breath. And then, as if I saw a patient, you know, out on the street that I was concerned about, I'd then go and check for a verbal response, ask them to open their eyes for me. And then obviously, if I can't get a verbal response, I'll then check for a pain response. And then eventually feel for a central heartbeat. And obviously, in any other situation, that's when you would commence CPR. But obviously, this being a patient who's got a DNA CPR in place or is an expected death, you won't do that at that point. So that's when you can go on and check the heart sounds and checking the eyes for response. So it's just a systematic approach, just to make sure you cover all areas. So there's no specific amount of time that you're supposed to listen to heart and chest sounds for. The recommendation is at least 2 minutes. Some say at least 5 minutes. I will get out my phone and actually get a timer on to make sure I do the 2 minutes, because it can feel like a long time when you're listening to nothing. It feels like a very long time and you're not quite sure how much has passed, especially when it's in the middle of a night shift and you've just woken up. So obviously making sure that if the patient's next of kin's there with you, explaining what you're doing as you go along. And obviously if you're getting your phone out, it's important just to explain that you're just timing it and that you'll have to remain quiet. We can use an ECG. If you're unsure, often when you're listening for the heart sounds, you can hear the movement of your hand or hear the stethoscope rubbing against their chest, which can put you off. So if in that situation, you can ask for an ECG, and obviously you'd be checking for asystole. So documenting, this comes from Antiemetics as well, is really important. So it's important to state whether the patient had a valid DNA CPR in place. Note whether the death was expected or unexpected. That'll help you decide whether it needs to be referred to a coroner. Note each step in the exam. So you specifically write, you know, checked for verbal response, no response, checked for painful stimuli, no response, you know, listen to the heart for over 2 minutes with no sounds heard. So you want to put each individual finding that you've put down. You want to document whether the next of kin has been updated, because it can cause a lot of trouble if people come in the morning and they don't even know if the next of kin have been told. The time of death is the time that you complete the exam. So often on a busy night shift, you might be asked by one of the nurses to confirm death for one of the patients. However, other patients take priority. So it has to happen a couple of hours later, but you can't put the time which the nurse told you. You have to put the time that you actually completed the exam, and you put that to the nearest minute. So you want the exact time. And then it's good practice to put all of your contact detail to make sure that anyone can contact you if they need to. And like I said, all this information I got from Antiemetics. The cruise website is a website for bereavement. It's a good thing to have up your sleeve in OSCEs if you're having to console a next of kin, or give them a bit of information of somewhere they can go. And it's also really good in real life if you have patients who are not sure what to do or how to process it. You can point them towards the cruise website. So last question, almost there. So you're a 91-year-old female in hospice, with a background of type 1 diabetes, AF, asthma, and hypothyroidism with an eGFR of 67. Her medication are as below. You wish to rationalize her medication to reduce her pill burden. Which of the following medications would be most appropriate to stop? Yeah, so this is quite an easy one to end with. So I would say atorvastatin is probably the most appropriate to stop. The reason for this is that statins give you benefits over years to decades, more decades really. And any benefit that she would have gained has most likely already happened by now. And the small amount of benefit she would be gaining is probably at too high a cost for the pill burden. So if you want to understand more about statins, there's a really good video by Rohan Francis, who's a cardiologist who also is a YouTuber, and he explains statins and the benefit that people derive from them. And it's a really good video to direct your patients to as well. It gives a really clear understanding of the pros and cons of statins. So just quickly on pill burden, so that's just simply the number of tablets or capsules that you take every day, and it's the bad consequences of having to take too many, not only the side effects and the interactions, but obviously the problem with storing the pills, having to go get the pills, having to pay for them, swallowing difficulties, remembering what they're for and at what time of day to have them. Some patients can be on 10+ pills a day. That's not that uncommon, and it can be a real cause of strife. So trying to reduce that pill burden is a positive thing to do. So the stop-start criteria are used not solely in palliative care, but in geriatric care, mostly in general. It gives a brilliant list as to reasons why you might want to stop some of the medications and reasons why you might want to start other medications. And you'll see in clinical practice that patients may be started on medications years ago that have had their benefit, but they're very good at starting medication. We're not actually very good at stopping medications. So it's a really helpful tool to use. So that's all the questions I got. I hope they weren't too difficult or too easy, and I hope that my explanations were useful. So just some of my top tips for the PSA if you haven't already done it. So for me, using the Control F function is really useful. I think probably most people know about this, but trying to skip to the certain bit of the BNF that you need by searching, specific search requests is really, really useful. I only learned this quite late, but there's Stockley's interaction checker on Medicines Complete. So there'll be lots of questions about interactions of certain medications, which the BNF doesn't have a very good interactions checker, but the Medicines Complete has one. So I had both loaded up when I was doing my PSA. So there's the good medicines guidance section on the BNF. So that's where a lot of the information I got today was from. So the palliative care section is really useful. It has all the opioid conversion tables, which obviously there'll be questions on. And then just quick ones which scuppered me. So like 1% solution, like a cream, means 1 gram in 100 mils. Something quite simple, but obviously quite important to remember and easy to forget. And then always check units, micrograms versus milligrams. Often in the medication review, there'll be a drug which is supposed to be in micrograms, but is actually in milligrams. And then best to always consider renal function and allergies, as there'll be reasons for prescribing one drug over another. And that's true of real life as well. Obviously, very, very important to check the allergies is the first thing you do.
So that's the end of the slides. Thank you very much for listening, and thanks everyone for contributing. I hope you found that useful. Obviously, if you have any feedback, please feel free to fill out the feedback survey with the QR code seen there, and you can have a copy of the slides. Obviously, if you have any extended questions, feel free to email me, and I'll try my best to answer you.
And if you're listening on YouTube, we leave the feedback form open for quite a while, so please do fill it in if you're listening online. And thank you again, Ollie.
Thanks, guys. Bye now.